Good morning, good afternoon, good evening, colleagues, depending on where you are. On behalf of the International Conference Committee, Professor Eli Katabira, the co-chair, and on my own behalf, I wish to welcome you to the 15th Interest Conference. This is our second virtual conference after the 14th Interest. My name is Kwesi Tope, the Acting Dean of the University of Ghana School of Public Health and the Scientific Chair for Interest 2021. Interest has grown from its humble beginnings, from the first meeting in Munyonyo in Kampala in 2007, to a vibrant conference and permanent fixture on our conference calendar on the continent of Africa. Despite its growth, Interest has maintained its core mandate of knowledge exchange and capacity building of young scientists on the continent. I acknowledge the work of our co-founders, Professor Joop Lange and Charles Boucher, for their foresight. I also recognize the immediate past scientific chair, Professor Kate Hankins, for her contribution to the Interest movement. For this year, we will present an exciting menu of topics, including the global HIV updates, COVID-19 and HIV, long-acting agents for treatment and for PrEP, access to medicines, HIV in children and adolescents, resistance, and many more. The state-of-the-art presentation will be delivered by an experienced and able faculty. The day 3 of this conference will be dedicated to our co-founder, Professor Charles Boucher. Ladies and gentlemen, I wish you a productive Interest 2021 and all that it offers. I also like to say a big thank you for your continuous support for this Interest movement. Thank you and enjoy the meeting. Now, I think I also want to perform another important duty. Interest has grown over time because of the contribution of a lot of people. Unfortunately, we have lost some of these colleagues. So the Interest Conference, as I said earlier, has been an important conference on our continent for the last 15 years. And during this period, several people have dedicated their time and lives to the cause of this movement. We lost Joop and Jacqueline in 2014 from the Malaysia Airlines M17 crash. This was a huge loss to the Interest family. At the turn of 2021, we lost David Kazakhstan in Zimbabwe. That's on January 25th. The following day, death laid its icy hands on Professor James Hakim, also in Zimbabwe. In February 26th, we had the sad news of Professor Charles Boucher's demise. Early in 2020, I think you all recall that we also lost Gita Ramji in South Africa. We salute their contribution to HIV prevention, care and treatment in Africa and in the Interest family. We are guided by Abraham Lincoln, who said, and I quote, "A nation that does not honor its heroes will not long endure." It is proper that those of us who are enjoying the benefits of their dedication and hard work acknowledge their effort and honor them. Charles, James, David, Gita, thank you for all that you have done for the continent. The Interest family owes a debt of gratitude to these outstanding professionals and scientists. May their souls rest in perfect peace.
When I was nominated to be a local chair for Interest Conference in 2017 in Malawi, I asked myself, what would it take to host a successful conference? I knew late Professor James Hakim through AIDS Clinical Trials Group through my affiliation with the University of North Carolina. And as a local chair for Interest Conference in 2015 in Harare, he advised me that the magic is to involve all stakeholders, including implementing partners, researchers, academia, civil society, and the donors in the organizing committee. And I'm glad I asked him. He was such a visionary strategic research scientist and a mentor, and I will always remember him for that.
had the privilege of meeting James at many international fora and many meetings. James represented for me the best of what we had. Not just a great scientific mind, but a man who had compassion, a man who had vision, and a man who focused on mentoring individuals so that the work he did would not come to an end, but continue because of the effort that he made in growing others. He is and will continue to be dearly missed.
But the legacy that he put down is laid down forever. The one aspect that we call the whole continent to remember is that despite all the challenges, Prof. James will always look imperturbable. You will never see the expression of his face. He's always calm. Every situation comes, he will talk gently and very calm. We need to learn from that leadership perspective. Hard-working person, we need to take that one for him. I cannot continue, otherwise I will never end up this speech. Well, I will call the whole continent, especially people who are in the leadership position, to try to emulate Prof. James Hakeem. We remember him forever. Thank you so much.
Today, I am the person that I am because of Prof. Hakeem. I really am better for having known Prof. Hakeem. I really hope we find joy and comfort in remembering him and the work he did. He was a dedicated mentor, a humble teacher with a kind heart. He really was a gentle giant, a giant on whose shoulders some of us rose and stood. So I really want to remember Prof. Hakeem and thank him for molding me into the good doctor that I am, into the world-renowned researcher that I am. May his soul rest in eternal peace.
Colleagues, ladies and gentlemen, let me welcome our opening speaker, who will deliver the topic, the global HIV updates, and that is in the person of Dr. Paula Manderi. Dr. Paula Manderi is the HIV prevention team leader and coordinator of the UNAIDS Global HIV Prevention Coalition, leading in strategic guidance provision to prevent new HIV infections. Before joining UNAIDS, Dr. Manderi was the Vice President of Programs for the International Association of Providers of AIDS Care, IPAC, and oversaw HIV response support in Fast Track Cities initiative. Dr. Manderi worked for the Uganda Virus Institute for 15 years, where she helped establish HIV research for the UK Medical Research Council. She was a principal investigator in the landmark DAT and START trials. Dr. Manderi graduated from the Makerere University School of Medicine and is a fellow of the Royal College of Physicians in Edinburgh. Ladies and gentlemen, please let's welcome Dr. Paula Manderi.
Hello, everyone. It is a great pleasure to be attending Interest Again and to be sharing with you a brief global HIV/AIDS update, as well as to introduce to you the global AIDS strategy and the next generation of goals for the global AIDS response. 2020 was a significant milestone year for the global HIV response. I'd like to start by recalling here the fast-track strategy to end the AIDS epidemic by 2030 that was endorsed by the UN General Assembly, as well as the targets that we as a global public health community adopted. By 2020, we set out to achieve the 90-90-90 testing, treatment, and virus suppression targets, to have reduced new HIV infections among adults to less than 500,000, and to have achieved zero discrimination against people living with HIV. How are we doing so far? AIDS-related deaths have dropped dramatically, and this is majorly as a result of effective HIV treatment, as well as progress in preventing TB among people living with HIV becoming increasingly available. We went from just over 50,000 people on HIV treatment in the year 2000 to over 26 million people on HIV treatment by June 2020. But not everyone is benefiting, because 680,000 people died of AIDS-related causes in 2020, exceeding the fast-track target of less than 500,000 deaths. Data show that more males are dying than females, and that the rate of mortality among children living with HIV is higher than that in adults. We have become accustomed now to looking at the testing and treatment cascades, and we see in this slide this year's update showing clearly that testing and treatment services are missing men. Men are less likely to get diagnosed, less likely to get linked to treatment, and even on treatment, they are less likely to achieve virus suppression. In terms of HIV treatment, children are still being left behind. Gaps in the testing of children exposed to HIV have left more than 2/5 of children living with HIV undiagnosed. The number of children on treatment continued to decline in 2020, and almost 800,000 children living with HIV were not on antiretroviral therapy in 2020. We have done particularly badly at stemming the tide of new HIV infections. An estimated 1.5 million new HIV infections occurred in 2020, and this is still 3 times higher than the fast-track target of less than 500,000 by 2020. This is despite having a widening array of effective HIV treatment prevention interventions at our disposal. We are still failing to deliver these evidence-based HIV prevention measures to priority populations at risk of HIV at an adequate scale to achieve the desired impact. Globally, the lack of progress in reducing new HIV infections among key populations is what is driving our overall failure to achieve our targets. Key populations and their sexual partners accounted for 65% of all new HIV infections globally. And our data in 2020 once again confirm the markedly increased risk to acquiring HIV/AIDS of key population groups. Gay men and other men who have sex with men are 25 times at greater risk. Female sex workers, 26 times at greater risk. Transgender women, 34 times greater risk. And people who inject drugs, 35 times greater risk. In sub-Saharan Africa, adolescent girls and young women aged 15 to 24 years are a priority population at risk for HIV infection, even though they only account for 10% of the total population. They account for 23% of new HIV infections in the sub-Saharan Africa region. This graphic shows a mapping of subnational regions color-coded by HIV incidence. In 38 countries from sub-Saharan Africa for which we have data, there were 661 subnational locations, or if you want to think of them as districts, of varying degrees of HIV, of high HIV incidence. In 2020, just 30% of these locations had dedicated HIV programs for adolescent girls and young women. This is a failure in coverage and among one of the reasons why we are failing to stem the tide of new HIV infections. In this next slide, I'd like to recall that the efficacy of PrEP, or pre-exposure prophylaxis, in preventing infection among people at significant risk of HIV can no longer be disputed. Yet the uptake of pre-exposure prophylaxis has been inadequate and unequal. Compared to the goal for 2020 of getting 3 million people at significant risk of HIV on PrEP, 845,000 people in at least 54 countries received PrEP in 2020. And further analysis show that the scale-up of PrEP is highly concentrated in only a small number of countries. For example, among the 28 focus countries of the Global HIV Prevention Coalition, only 6 countries account for over 80% of the people on PrEP last year. Finally, we were very proud that there had been great progress in reducing new HIV infections among newborns exposed to HIV over the past decade. But in the past 2 or 3 years, this progress has stalled. The reasons vary country by country, but we have adequate data to enable us to address the specific gaps in specific programs. I'm showing on this slide rates of new vertical HIV infections by mode of transmission in last year's data. As you will see, a significant number of infections occur because mothers acquired HIV during HIV pregnancy. A more significant number occur because mothers did not receive what we know to be effective antiretroviral therapy during pregnancy, or they received treatment and were not virally suppressed, or they got off treatment during pregnancy. So many of the 150,000 newborn HIV infections in 2020 could have been prevented if we could ensure that all pregnant women living with HIV are receiving treatment, that pregnant and breastfeeding women are supported to continue treatment, if we protect women from becoming newly infected during pregnancy and breastfeeding, and if we optimize treatment regimens among pregnant and breastfeeding women to ensure optimal viral suppression. What I have just described are only some of the inequalities in service access and opportunity and scale up that are showing up as inequalities in response between and within countries and communities, and that are preventing the world from ending AIDS. I would encourage you to read the full document, End Inequalities, End AIDS, which is the Global AIDS Strategy for 2021 to 2026 that is shown here. It is a universal strategy, not a UNAIDS strategy, as in the title of this presentation. And while UNAIDS led the development of this strategy, it features the inputs and engagement from over 10,000 participants from at least 160 countries worldwide. The Global AIDS Strategy aims to end the inequalities that prevent progress to ending AIDS. It provides the best synthesis of evidence and is based on evidence, the best synthesis of policies and priority actions to support every country and every community to make progress. In addition, it features new bold targets and evidence-based actions for 2025 to get every country and every community back on track to end AIDS as a public health threat by 2030. The next generation of goals, or the new 2025 targets, are based on evidence, are based on an extensive evidence review conducted by UNAIDS, and they capture evidence-based interventions that, if we can take them to the targeted scale, will lead to achievements against new HIV infections, AIDS-related deaths, and stigma and discrimination. Very briefly, the new targets call for 90% coverage of core evidence-based HIV services. They set clear targets for the removal of societal and legal impediments to accessing services, and they emphasize people-centered, context-specific service integration. Again, I would strongly recommend that you read this brief report released by UNAIDS last year on World AIDS Day called Prevailing Against Epidemics, that gives an excellent background to the new UNAIDS 2025 targets. And as I close, I'd like to share with you this modeled impact of reaching the strategy's targets and commitments. The number of people who newly acquire HIV will decrease to less than 370,000 by 2025. And the number of people dying from AIDS-related illnesses will decrease to less than 250,000 in 2025. This is the anticipated impact of implementing fully the new global AIDS strategy and the new 2025 commitments. And this would put the world on track to reach the 2030 target of ending AIDS. I would also like to invite you to visit the web pages listed here for more data. For more data on the epidemic and for more data on the service coverage and interventions that are necessary to get us to where we want to go. Thank you very much for inviting me to participate once again in Interest. And thank you very much for allowing us to share our exciting new goals for this decade of action.
Thanks, Paula, for the brilliant presentation on the Global HIV/AIDS updates, the UNAIDS strategy to end AIDS in 2020. Thank you very much for the presentation. And at this juncture, I would like to hand over to Tim and Elizabeth to take over for the next session that will discuss increased availability of COVID-19 vaccines and HIV prevention technologies. Thank you.
Good day, colleagues. I'm Dr. Tim Mastro, Chief Science Officer with FHI 360 in Durham, North Carolina, USA. My co-chair today is my friend and colleague, Dr. Elizabeth Bakusi, who is Chief Research Officer at the Kenya Medical Research Institute in Nairobi and a research professor at the University of Washington. There will be 3 presentations in this session, the James Hakim Memorial Lecture and 2 invited scientific talks. I encourage you all to put your questions in the chat. There will be a live discussion and Q&A session after the 3rd presentation has finished. It is a great honor for me to introduce the creation of the James Hakim Memorial Lecture here at Interest 2021. James was a dear friend and colleague of all of us in the Interest and HIV research families. Professor James Gita Hakim was born in current-day South Sudan in May 1954. He tragically died at age 66 from COVID-19 related complications on January 2021, earlier this year, in his home country of Zimbabwe. In 1979, James began medical training at Makerere University in Uganda, continued at the University of Nairobi in Kenya, then specialized in cardiology at the University of Aachen in Germany. In 1992, he lectured at the University of Zimbabwe College of Health Sciences and eventually became a senior lecturer and professor. He served as a consultant physician at the Harare Central Hospital at Parenye Datua Hospital in Zimbabwe. He was also a leader in the DART trials in Africa, proving that treatment did not require extensive laboratory monitoring. James was a lead investigator of several key studies conducted by the HIV Prevention Trials Network of the U.S. National Institutes of Health. James was local chair for Interest 2015 in Harare, Zimbabwe, and a member of the Interest International Conference Committee. An outstanding clinician and educator, James helped develop health capacity by teaching many young Africans. Today, we recognize James for his leadership and vision in keeping the Interest flame alive. The annual James Hakim Memorial Lecture will immortalize his legacy and contributions to the Interest family and to Africa as a whole. To deliver the first James Hakim Memorial Lecture on the topic Access to COVID-19 Vaccines in Africa, a situation analysis and local manufacturing options, there is no one better suited than Dr. John Nkengasong, who since 2016 has been the founding director of the Africa Centers for Disease Control. I had the privilege of counting John as a colleague and a friend for 25 years, going back to our time together at the US CDC. As one of the WHO Director General's special envoys on COVID-19 preparedness and response, he recently received the Bill and Melinda Gates Foundation's 2020 Global Goalkeeper Award. He previously served as acting deputy principal director for the Global Center for Global Health and chief of the International Laboratory Branch in the Division of Global HIV and TB for US CDC. Dr. Nkengasong holds a tropical biomedical science degree from the Institute of Tropical Medicine in Antwerp, Belgium, and a doctorate in medical sciences, namely virology, from the University of Brussels in Belgium. Dr. Nkengasong has received numerous awards, including the Shepherd Award, the William Watson Medal for Excellence from the US CDC, and the Knight of Honor Medal from the Government of Cote d'Ivoire. He was knighted both in 2017 as the Officer of Lion by the President of Senegal, and in November 2018 by the Government of Cameroon. He is an adjunct professor at the Rollins School of Public Health at Emory University in Atlanta, Georgia. It's with great pleasure that I introduce John to you all. Thank you.
Greetings from the Africa Centers for Disease Control and Prevention, based at the African Union in Addis Ababa, Ethiopia. It is an honor for me to deliver the James Hakim Memorial Lecture. And in the next couple of minutes, in the time allotted, I will discuss access to COVID-19 vaccines in Africa, focusing on the situational analysis and local manufacturing options. First of all, let's reflect on Professor James Hakim, who unfortunately died because of COVID very early on in this pandemic. James was an outstanding African researcher who dedicated his life to clinical research, scientific research, and social justice. The slide you see here shows you the current situation of COVID-19 in Africa. As of September 24th, 8.2 million cases of COVID have been officially reported to the Africa Centers for Disease Control and Prevention. Of that number, 7.6 million, or 90%, have recovered, and 208,000 people have unfortunately died, representing a case fatality rate of 2.5%. The graph on your right-hand side shows the daily COVID-19 cases and represents the three peaks that the continent has witnessed. The first peak, or the first wave, peaked around July and August of last year. And then towards the end of the year and beginning of 2021, we witnessed the second peak, where at that time, we were reporting about 32,000 cases per day. And we have now just witnessed the peak of the third wave, where we're observing about 45,000 cases per day. The different colors you see underneath this curve represents the regions, the 5 geographic regions of the continent. For example, the pink color you see there is Southern Africa. Clearly, you can see that nearly every 2 months, we have a peak, and then we fight hard by locking down the economies and intensifying public health measures, and then bring down the daily cases significantly. As you can see on the third wave, if I can just focus on that, each time we see a wave, it brings a devastation to the economy and lives. Just during the last wave, about 72,000 people died in Africa. And we recorded about 3 million new cases out of the 8 million that I just represented during this last phase. As a continent, Africa consumes about 1.3 billion doses of vaccines annually. This is not just COVID vaccines, but I mean all vaccines included. However, as a continent, we import about 99% of our vaccines and only manufacture about 1% of the vaccines. That is about 12 million doses of vaccines out of the billion that I just indicated are manufactured rather in Africa. The slide here shows you the sites that are currently manufacturing some types of vaccines. And I will just pause here to say that of all these sites, only the yellow fever vaccine produced at the Institut Pasteur in Senegal, in Dakar, Senegal, are actually licensed by the WHO. Most countries have no vaccine manufacturing capacity, as you can see on the map very clearly. And this has consequences on how and why Africa lags behind in the current struggle to access to COVID vaccines. The map you see here shows you the countries, how countries have flared in terms of vaccinating their people. The greener the color, the more people have been vaccinated, and the red colors indicate where vaccination programs are significantly lagging behind. You can clearly see that the continent of Africa is significantly, as a whole, lagging behind the vaccination programs for COVID. I just wanted to zoom in a little bit and compare Africa, a continent of 1.2 billion people, with the rest of the world. China has vaccinated about 71% of its people fully, and about 5% partially vaccinated, for a total of about 76%. The United States has vaccinated about 54% of its population fully, and about 9% partially vaccinated, for a total of about 63%. Europe is around 56%, with 51% fully vaccinated. India is reporting a 15% fully vaccinated rate, with 29% partially vaccinated. And the world as a whole has vaccinated about 44% of its population. But if you compare Africa, the last bar, it shows that only 4% of a population of 1.2 billion people have been fully vaccinated. And for a total of about 6.1% if you include those who have been partially vaccinated. Vaccination in Africa, or lack of, has significant effect on both our health systems and our healthcare workers. A recent publication in Science in February clearly indicated that deaths of healthcare workers in Africa highlights the need of inequity. But Harkin's death also highlights to the coronavirus pandemic. This is all excerpts from that Science piece. At the Africa CDC and African Union, we have adopted a strategy that was first endorsed by the Bureau of the Head of States last year, given where we are in this pandemic. And this adapted strategy focuses on a couple of things. The need to enhance the monitoring of these viruses, the need to enhance our prevention strategy, and the need to enhance our treatment, and of course, scale up vaccines. So let us, first of all, examine where we are with the vaccination program in detail in Africa. As of September 23rd, 2021, a total of 181 million doses of vaccines have been supplied in Africa, of which 136 million have been administered, representing a consumption rate of 75% from 53 member states. The slide on your right-hand side shows by intensity how countries have used up these vaccines. I think it clearly shows that many countries are still lagging in their access to vaccines and rollout of vaccination programs. However, some countries are making progress, like Morocco, who has vaccinated about 48% of its eligible population, Mauritius about 61%, and Seychelles 70%. What are the needs for the continent? Last year, we went to the Bureau of the Head of States of the African Union and presented the need for us to at least vaccinate 60% of our population, eligible population. And that would have meant that we vaccinate at least 800 million people. And that would require that we mobilize 1.6 billion doses of vaccines. COVAX, which is the multilateral mechanism supported by Gavi, the World Health Organization, the Coalition for Epidemic Preparedness, Innovation, and UNICEF, had promised the continent that they would support it with about 26% of its needs. Then we therefore established AVAT, which is the African Vaccine Acquisition Task Team, which is supported by funding from the Afro-Exim Bank, to immunize up to about 31% of our population by acquiring 400 million doses from the Johnson & Johnson. The political leadership of our continent has been extraordinary in mobilizing the continent towards this vaccine initiative and reaching our targets. As you will see on this slide, in August last year, President Cyril Ramaphosa, who was the chair of the African Union at that time, established AVAT. And in April this year, President Tshisekedi, the current chair of the African Union, launched the Partnership for African Vaccine Manufacturing, abbreviated PAM. And as I indicated earlier, COVAX has signed an agreement, AVAT, I beg your pardon, has signed an agreement with the Johnson & Johnson to secure about 400 million doses of vaccine to achieve at least a 31% coverage. I must pause here to indicate that these vaccines are not donations, but these are vaccines that have been procured by member states, by their own funding from member states, supported with the World Bank and, of course, the Afro-Exim Bank. Another initiative and support that has come on is the partnership with the MasterCard Foundation. You're all aware that last year, or this year, on June 8th, the MasterCard Foundation and Africa CDC announced a $1.3 billion initiative or program that is aimed at securing about 50 million doses of vaccines, covering that will enable us to achieve our 60% target to achieve herd immunity. This program, that is the MasterCard Foundation Partnership, has 4 pillars. Pillar number 1, I indicated, is to purchase at least 50 million doses of vaccines. Pillar number 2 is to deploy vaccines, that is the vaccination component. Pillar number 3 is to support manufacturing of vaccines, focusing on the human capital. And pillar number 4 is strengthening Africa's capacity. There has been much talk with respect to whether if vaccines are made available in Africa, people will take it up. Our position in this has been very clear, that the challenge we have in our hands is lack of vaccines and not vaccine hesitancy. As you can see on this video, on your left-hand side, these are Moroccans who have queued up in the stadium in Tangier to receive their vaccines. You can see that they are queuing long lines of people spreading and winding inside the stadium and outside of the stadium. You can also see on your right-hand side how people are queuing up in front of clinics in Rwanda and Zimbabwe to receive their vaccines. So if vaccines are available, we remain very optimistic at the Africa CDC that there will be effective uptake of those vaccines. The continental leadership has also been very busy trying to expand vaccine manufacturing on the continent. On April the 12th and 13th, the entire leadership of our continent gathered under the umbrella of a conference or a summit we called to look at how Africa can expand its vaccine manufacturing. President Tshisekedi, President Ramaphosa, President Kagame, Chairperson Moussa Faki, Dr. Tedros, the Director General of WHO, Dr. Ngozi, the Director General of ITM, Winnie, Dr. Vera Songwe, and Senaid were all present. At that meeting, 40 participants took part in a 2-day summit and representing 70 countries. At the end of that meeting, we agreed that we need to develop a roadmap for the continent, which I'll come back to. But expanding vaccine manufacturing in Africa will require that we clearly have vaccines that will address COVID, but also some African-specific outbreaks, that we support the strong demand growth, and which is based and informed by the increasing population of the continent and immunization gaps, that we look at our patterns of emerging and re-emerging outbreaks, and how we look at evolving economies driven by new technologies and more supportive environments. Because of this, the Africa CDC has actually put forward the concept of a new public health order for the continent that is hinged on 4 pillars. One, the need to strengthen our public health institutes and institutions, strengthen our public health workforce, expand our vaccine manufacturing, diagnostics, and therapeutics, and what we call respectful, action-oriented partnerships. Let me just expand a little bit on what our vision is for vaccine manufacturing on the continent that will enable us to build back better, bolder, and bigger. I indicated earlier that as a continent, we import 99% of our vaccines and produce 1% locally. Our vision for 2024 is that we should be able to manufacture at least 60% of our vaccines and only import 40% of the vaccines. There will be potential barriers we need to address. We need to have an agenda setting and coordination mechanism, a continent-wide regulation and harmonization, a predictable and steady access to finance, talents and know-how, and the right infrastructure to enable us achieve that ambitious target of manufacturing 60% of our vaccines. President Tshisekedi, as I indicated earlier, on February 12, in his capacity as chair of the African Union, launched the Partnership for African Vaccine Manufacturing. And we invite all of you to work with us in the framework of this partnership agreement to advance vaccine manufacturing on the continent. We have since made progress, and we hope that by December, a framework for action would have been adopted and presented in front of the head of states when they meet in February at the summit. This slide shows you some research hubs that we hope we can promote through this initiative. We envision that by region, and the different colors represent the 5 geographic regions of the African Union member states, we should have research hubs placed within each of these centers and these regions and strengthen them so that they can take part in research and development of what it will be required to produce vaccines on the continent. Professor James Hakim was an exceptional cardiologist and a brilliant and a committed HIV researcher. We always remember him for the groundbreaking work he did in research and the kind of work he did to promote and advance clinical trials for HIV is the same kind of spirit, commitment, dedication that we should apply in our efforts to produce vaccines locally on the continent. But we should not end there. We should actually also look at ways we can design research and development so that the hubs can also produce diagnostics and pharmaceutical. I'm very sure that if Professor Hakim was here today, you would have agreed with this quote from Nelson Mandela, where he says, "It always seems impossible until it is done." I thank you for your attention and for the opportunity to give this lecture.